Hello and welcome. Today we'll be exploring a complex and often underdiagnosed condition affecting the kidneys: atheroembolic renal disease, also known as cholesterol-emboli disease of the kidneys. Join us as we delve into the causes, effects, and management of this important condition. Atheroembolic renal disease arises from the dislodgement of cholesterol crystals from atherosclerotic plaques in the aorta, or large arteries. These plaques, built up over time from cholesterol and other substances, can become unstable. A triggering event, such as an invasive vascular procedure like angiography or surgery, or even anticoagulation therapy, can cause fragments of these plaques to break off. These fragments, consisting primarily of cholesterol crystals, then travel through the bloodstream. Once these cholesterol emboli are released, they travel downstream and eventually lodge in the smaller blood vessels of the kidneys. This physical blockage obstructs blood flow, leading to ischemia, or a lack of oxygen and nutrients, in the affected tissues. The presence of these cholesterol crystals also triggers an inflammatory response within the kidney. This inflammation further damages the blood vessels and surrounding renal tissue, contributing to kidney dysfunction. Over time, this persistent obstruction and inflammation can lead to progressive kidney damage and even kidney failure. Atheroembolic renal disease is more common in older individuals, particularly those with pre-existing atherosclerosis or cardiovascular disease. It's estimated to occur in a small percentage of patients undergoing invasive vascular procedures, with the incidence varying depending on the specific procedure and the patient's risk factors. The exact prevalence in the general population is difficult to determine, as the condition can be easily overlooked or misdiagnosed. The signs and symptoms of atheroembolic renal disease can be quite variable and may develop gradually over weeks or months after the initial embolic event. Common symptoms include acute or subacute kidney injury, leading to elevated creatinine levels in the blood. Other manifestations can include skin findings such as livedo reticularis, a mottled, net-like pattern on the skin, especially on the lower extremities, and blue toe syndrome, characterized by painful, cyanotic toes. Systemic symptoms such as fever, weight loss, and muscle aches may also occur due to the inflammatory response. In some cases, the emboli can affect other organs, leading to symptoms related to those specific areas. Diagnosing atheroembolic renal disease can be challenging due to its varied presentation. The diagnosis often relies on a combination of clinical findings, laboratory tests, and imaging studies. Blood tests may reveal elevated creatinine levels, eosinophilia, and an elevated erythrocyte sedimentation rate (ESR). Urinalysis might show proteinuria and microscopic hematuria. Definitive diagnosis usually requires a kidney biopsy. Microscopic examination of the biopsy sample will reveal the characteristic cholesterol crystals within the renal arteries, confirming the diagnosis. Atheroembolic renal disease doesn't have distinct classifications or types in the traditional sense. However, it can be categorized based on the severity of kidney dysfunction and the extent of involvement of other organs. Some patients may have mild, self-limiting disease, while others may experience progressive kidney failure requiring dialysis. Unfortunately, there is no specific cure for atheroembolic renal disease. Treatment focuses on supportive care and managing the symptoms. This may include controlling blood pressure, managing fluid balance, and providing dialysis if kidney failure develops. In some cases, statins may be used to stabilize atherosclerotic plaques and prevent further embolization, although their effectiveness in established atheroembolic disease is debated. Antiplatelet medications may be considered to reduce the risk of clot formation, but their use must be carefully weighed against the risk of bleeding. Controlling underlying risk factors such as hypertension, diabetes, and hyperlipidemia is also crucial. Preventing atheroembolic renal disease primarily involves managing risk factors for atherosclerosis and taking precautions during invasive vascular procedures. This includes controlling blood pressure, cholesterol levels, and blood sugar, as well as encouraging lifestyle modifications such as quitting smoking and maintaining a healthy weight. When undergoing invasive vascular procedures, careful technique and minimizing manipulation of the aorta can help reduce the risk of plaque dislodgement. In some cases, the use of embolic protection devices during these procedures may be considered. The prognosis of atheroembolic renal disease is variable and depends on the severity of kidney damage, the extent of involvement of other organs, and the patient's overall health. Some patients may experience spontaneous improvement or stabilization of kidney function, while others may progress to end-stage renal disease requiring long-term dialysis. Recent research has focused on identifying biomarkers that can help predict the prognosis and response to treatment. Studies are also exploring the potential role of anti-inflammatory therapies in reducing the inflammatory response associated with the disease. Further research is needed to develop more effective treatments and improve outcomes for patients with atheroembolic renal disease. Thank you for joining us for this overview.